Question 1. Which of the following modalities has proven most effective for monitoring patients undergoing procedural sedation? Capnometry or capnography? B. Cardiac rhythm monitoring. C. Continual direct visual observation of qualitative clinical signs. D. Documented respiratory rate. E. Pulse oximetry. The answer is C. Continual direct visual observation of qualitative clinical signs. The patient's ability to follow commands in response to varied levels of stimulation and direct observation of the ventilatory status have been the most reliably documented methods of assessing the level of consciousness during procedural sedation. Pulse oximetry is a reliable adjunct, but it identifies hypoventilation late, especially when used with supplemental oxygen. Cardiac monitoring has been shown to be helpful in older patients or in those with a history of cardiac disease, but there is no evidence that it is of any benefit in young healthy patients. End-tidal carbon dioxide monitoring has been shown to be useful to detect inadequate ventilation earlier than oximetry, especially when direct observation of the patient is difficult, but no studies have demonstrated an effect on clinical outcome to date. The American Society of Anesthesiologists has updated its procedural sedation standards to include capnography during moderate or deep sedation, in addition to the continual observation of qualitative clinical signs. Respiratory rate alone is an insensitive indicator of the adequacy of ventilation. Question 2. Which of the following statements is most accurate regarding the use of fentanyl for procedural sedation? Chest wall rigidity is a common occurrence but may be reversed with naloxone. B. For deep sedation, a single dose of 1 to 2 microgram kg intravenous is often given before sedation to achieve good pain control. A smaller dose of sedative agent may then be added and titrated to effect. C. Rapid intravenous administration is generally safe. D. Respiratory depression is less likely with fentanyl than with an equipotent dose of morphine. E. Sufficient analgesia is generally attained with dosages of 5 to 10 microgram kg intravenous. B. For deep sedation, a single dose of 1 to 2 microgram kg intravenous is often given before sedation to achieve good pain control. A smaller dose of sedative agent may then be added and titrated to effect. For deep sedation, less respiratory depression is generally observed if a single pain-relieving dose of fentanyl is used before sedation, followed by small titrated doses of a sedative agent. Sufficient analgesia is generally attained with fentanyl dosages of 1 to 2 microgram kg intravenous. Rapid intravenous administration of large doses is more likely to precipitate respiratory depression or arrest. Chest wall rigidity is very rarely seen and generally only with large, rapid intravenous boluses of more than 7 microgram kg intravenous. If severe chest wall rigidity syndrome is precipitated, it often requires paralysis to ventilate the patient adequately. It is not reversed with naloxone. Equivalent dosages of morphine show more histamine release and hypotension than fentanyl but have similar respiratory depression potential. Question 3. Which of the following agents is matched with the correct associated side effect? Etomidate limited, 30-minute duration of sedation. B. Ketamine laryngospasm. C. Methotrexate venorrhea. D. Pentobarbital seizures. E. Propofol myoclonus. The answer is B. Ketamine laryngospasm. Ketamine has been associated with laryngospasm in children younger than 3 months and those with a respiratory infection. The following are the other correct associations: methotrexate seizures, propofol venorrhea, pentobarbital 30-minute duration, etomidate myoclonus.